really all the reason we want to test for PIK3CA mutations is because of the SOLAR-1 data and our use of alpelisib. Priyanka, tell us a little bit about the use of alpelisib in SOLAR-1. What did that study show?
So the SOLAR-1 was a trial for women in second-line setting after progression on first-line aromatase inhibitor therapy, and showed the benefit of adding an alpha-specific PI3 kinase inhibitor, alpelisib, to backbone of fulvestrant. There was improvement in progression-free survival, which was clinically quite meaningful, almost a 6-month improvement. And that led to the approval of the drug last year, and now it's available for us to use in clinic. And that obviously has driven the clinical necessity to look for PI3 kinase mutations. In this trial, the benefit of alpelisib was noted primarily in patients who harbored a PI3 kinase mutation in the specified domains. And in SOLAR-1, about 40% of the patients had a PI3 kinase mutation when tested on tumor tissue.
It's an interesting question. I think the real question is, what are we seeing in the population at large in terms of PIK3CA mutations? But then what do you do with the patients who have already, either they don't have a mutation or they have already progressed or can't tolerate alpelisib for whatever reason? How are you using everolimus now, Tiffany?
So it's still one of the drugs in our armamentarium. And so depending on what the toxicity and concern was, you mentioned if somebody wasn't able to tolerate alpelisib, I'd want to be sure patients aren't having difficulty with pneumonitis as I'm thinking about using everolimus, but I still see it has a place. It just has moved down quite a bit in the lines of potential options for endocrine therapy partnered with exemestane. And there's evidence for partnering it also with tamoxifen even. So, sometimes in someone who's had a small level of progression but needs a change of therapy, has sequenced through all of our other available endocrine therapies and they're maybe PI3 kinase wild type, I would see that as an option with the steroid rinse to make the mucositis more manageable, if you will, as an alternative to moving on to chemotherapy.
And Priyanka, where do you tend to use everolimus, and what's your preferred partner with everolimus?
So I agree with Tiffany that, especially the patients that have a PI3 kinase mutation and cannot tolerate alpelisib, maybe because of diarrhea or a small proportion that develop significant rash, this is a useful drug. And for patients that haven't had fulvestrant, obviously that makes for the most rational partner. But I see a role in later lines of therapy as well, combining with aromasin or tamoxifen. I agree with the pneumonitis aspect. Obviously, patients who've had pneumonitis with alpelisib are probably at higher risk for having it with everolimus. But diarrhea and rash sometimes are one of the reasons we can't give alpelisib. Also, our patients that have hemoglobin A1C above the threshold that SOLAR-1 used or have uncontrolled diabetes.
Mm-hmm.
Yeah, I think it's a great question. Claudine, how are you managing when you give alpelisib to a patient with fulvestrant, how are you managing their blood testing and managing toxicity?
Well, I think obviously it's one of those drugs that makes us be better internists again. For some of us who are old and forgot some of this stuff, obviously we need to manage and follow their glucose carefully on this and be monitoring their hemoglobin A1C and really, I tend to follow the algorithm that's out there in terms of what we should be doing in terms of metformin dosing and a variety of things by monitoring there carefully for that.
Yeah, it was interesting. I mean, we just presented data at ESMO in 2019 about the time course of toxicity with alpelisib on SOLAR-1. And what we saw was that, if you're going to be hyperglycemic, you usually peak in the first 15 days, and the same with rash. We actually have encouraged people to use preventive antihistamines, and the non-sedating antihistamines seem to play a big role. And I've actually sort of doubled the dose in the first week or so for patients, and we just stopped seeing rash. It was kind of funny when we were doing the phase 1 studies, we saw tons of rash, and then we stopped seeing it. So I think that this is something like the steroid mouthwash that we used for everolimus stomatitis, that we can really minimize that toxicity. For the hyperglycemia, it's been interesting. I don't know if any of you talk to patients. There are a lot of patients who have sort of hemoglobin A1Cs that are slightly elevated. We know they're at higher risk. I've actually found the insulin-dependent diabetics easy because, they just modify their insulin. But for the other patients, do you talk to them about a low carbohydrate type diet, Tiffany?
Yeah, we do. So we check a baseline hemoglobin A1C, talk about just generally a low carb diet, have finger stick monitoring, glucose monitoring, and it's just been, as Claudine mentioned, kind of a new world and having to relearn diabetes management and something we haven't had to do for a long time.
Yeah, it is interesting. I mean, by the time I get past metformin, I'm usually getting my endocrinologists involved, and I'm guessing most of you guys are too. But there are new classes of drugs that we learn about on the television that we may have some guidelines for recommending, and that will help us a little bit because, our endocrinologists are also busy. So it's interesting. And then there's also some interest in combination therapies and how we're giving other alternative agents in the hormone receptor positive setting. I don't know if you have any perspective on where we're going to go with this moving forward, Priyanka?
So obviously, we've seen efficacy of AKT inhibitors in this setting with fulvestrant, and capivasertib is in phase 3 trial right now in second line setting after progression on first line AI therapy. And for that trial, it's enrolling regardless of PI3 kinase mutation status. So patients that don't have a mutation and otherwise a good fit, we're recommending that trial to the patients. So among the second line space, I see that as one of the other promises that hopefully will bear fruit.